For decades, the operational reality of modern medicine was measured in tons of paper. The core objective of health information management, or HIM, has always been straightforward: collect, store, and share the basic facts about people, clinical conditions, and medical procedures. In the era of the paper record, achieving that objective required an army of technicians. Extracting data meant reading through handwritten charts, creating paper abstracts, and physically mailing them to reporting agencies. This manual routing was dangerously fragile. Every time a human hand transcribed a note from a primary patient file to a secondary report, the risk of a medical error multiplied. The electronic health record, or EHR, emerged as the direct solution to these physical limitations. By digitizing patient files, hospitals eliminated illegible handwriting and dropped retrieval times from days to milliseconds. But replacing paper with information systems did not happen overnight. It was a decades-long evolution of software, hardware, and network infrastructure. This technological transition redefined the profession. HIM is now a clinical intelligence engine, providing insights that were completely impossible to extract from paper files. To understand this intelligence engine, we have to look at the hardware that runs it. Prior to the 1960s, healthcare computing meant massive mainframe machines relying on vacuum tubes that required extreme cooling and took up entire rooms. These early mainframes mostly handled basic financial applications, and as this unpunched grid shows, entering data into them was an entirely manual process. Technicians used punch card systems. The specific patterns of holes punched into these cards provided direct physical instructions to the computer, like telling it to enter a date of birth or update a patient's address. By the 1970s, memory capacity increased. Hospitals began installing departmental information systems, moving away from punch cards to keyboard-based desktop terminals. These early setups were what we call dumb terminals. A clerk could sit at a desk and input master patient index data, but the terminal itself had no processing power. All the actual computing was still handled down the hall on the central mainframe. Compare that centralized setup to today's infrastructure. Wireless connectivity protocols like Wi-Fi have completely decentralized the hardware. Computing power now exists at the point of care. Doctors and nurses document treatments at the exact time and location the patient is receiving them. This is often done using a COW, a computer on wheels, or a WOW, a wireless on wheels. These mobile carts move seamlessly from room to room. Shrinking the hardware freed the patient record from the basement, turning the computer into an active participant at the bedside. A computer at the bedside is useless if it can't talk to the pharmacy or the billing department. Devices in close physical proximity had to be linked together using local area networks. As these networks grew, healthcare organizations built intranets. This is a private, secure network located behind a firewall, used exclusively by internal employees to access hospital policies and resources. To communicate with the outside world, they use an extranet. This securely allows external users limited access through the firewall, like a patient checking their portal or a vendor monitoring hospital supply levels. Today, many organizations bypass local servers entirely through cloud computing. By uploading data to remote, vendor-owned systems, hospitals can access massive storage and analytics capabilities over the internet. However, as digital adoption spread, a massive logistical hurdle emerged. A hospital using one vendor's software couldn't read the files from a clinic using a different vendor. The data was trapped in isolated silos. Solving this required interoperability. This is the ability of different information technology systems and software applications to exchange data accurately, effectively, and consistently. This drive for interoperability created the Health Information Exchange. As this diagram illustrates, the exchange sits in the middle, allowing separate entities, like an individual physician and a medical center, to access the exact same patient record. Because of this hub, patient files securely flow back and forth between providers, regardless of which software vendor each clinic originally purchased. By solving the interoperability problem, the industry turned a fractured system of isolated clinics into a cohesive, collaborative intelligence network. With the hardware mobilized and the network interoperable, the primary focus of HIM shifts to the software, specifically how to extract value from these massive databases. This requires a strict distinction between raw data and manipulated information. As seen here, the statement 33% of patients have insurance is raw data. It lacks context. When you calculate that 33% had commercial insurance for December, marking a 2% year-over-year increase, that's information. The science of examining raw data to draw conclusions and generate that context is known as data analytics, which relies on tools like data mining and aggregated executive dashboards. In healthcare, this science is divided into a 4-tiered hierarchy, starting with descriptive analytics. This first tier looks strictly at the past to determine what already occurred, tracking metrics like patient volume changes over a 5-year period. Once we know what happened, we move to the second tier to understand the root cause, diagnostic analytics. Diagnostic tools help an organization determine exactly why a metric shifted. If descriptive analytics shows a drop in admissions, diagnostic analytics can investigate specific attributes to reveal that the decline was caused by losing a specific medical practice. The third tier shifts from reviewing historical facts to forecasting future odds, predictive analytics. This process uses machine learning algorithms and historical observations to project what is likely to happen next, such as calculating the expected readmission rate. Finally, we reach the most complex tier, prescriptive analytics. Prescriptive systems build on those predictions by automatically suggesting specific courses of action and detailing the implications of each choice. If a hospital leadership team is debating whether to open a new trauma center or a transplant center, prescriptive analytics will model the data and recommend which facility to establish. High-level analytics turn the EHR into an active strategy tool, converting historical facts into actionable future decisions. These information systems provide essential layers of safety that protect patient lives. Take computerized provider order entry, or CPOE. When a physician orders tests and medications digitally, the immediate benefit is the total elimination of illegible handwriting, which used to be a major cause of dangerous dosage errors. More importantly, information systems have built-in edits. If a doctor orders a tablet-only medication as a liquid, or inputs a dangerous drug combination, the system prevents the impossible data from being entered. At a macro level, analyzing millions of these interactions across the EHR facilitates evidence-based medicine. This relies on peer-reviewed biomedical studies to verify which treatments actually yield the best outcomes. The findings are then codified into clinical pathways and detailed practice guidelines, providing a coordinated step-by-step roadmap for practitioners to handle specific diagnoses. As the technology driving these pathways has evolved, so too has the daily reality of the health information management professional. With the elimination of manual paper routing, many healthcare organizations now run completely virtual or centralized HIM departments, allowing coders and analysts to manage data remotely. The required skill sets have moved past physical record maintenance. Today's professionals must be experts in system implementation, complex data governance, and data mining. This technical proficiency has generated highly specialized new roles, creating demand for data integrity analysts and mapping specialists. The digitization of healthcare infrastructure liberated the HIM profession from simply processing the past. Armed with powerful information systems, they now actively architect a safer, more predictive future for patient care.